right, so as we're talking about things that are going wrong, sexually speaking, about disease states, I want to give you all a brief introduction into this concept of addiction. Most of you have some sort of pop psychology understanding of it or some ideas about what addiction is. And I want to, there's, the DSM-5 has changed in terms of some of the things it does with that chapter. There's a whole chapter devoted to substance use disorders, and it's changed, and it's probably still going to be changing in the next edition, whatever that is. So I want to give you some ideas about up and coming things that will happen to it. But to start us off, I think addiction, this is my opinion, is a very human, easy thing to understand. And to what I'm trying to do here, actually, and what I'm doing with myself is I'm provoking a state of craving right now. I can feel my mouth starting to water. And for anybody who likes cheesecake, you see this picture, and you get some ideas in your head about how nice it would be to have a piece of cheesecake, or whatever it is you get hungry for. Most of us have struggled at one time or another with engaging in behaviors to a greater or lesser degree than we desire to, or than we plan to. Whether it's that you plan to study for 5 hours and ended up only studying for half an hour, or you plan to only drink 2 beers at that party, you ended up drinking 5 or 6. Many of us, we set off to do something and then we do something different. And I think if you can really empathize with this, you can understand what it's like to be in the brain or to be in the body of somebody that struggles with an actual addiction kind of diagnosis. I argue that almost all of us can relate to this. So let's get a few words clear here. Now, we used to somewhat distinguish between these 3 words that are on the screen: dependence, abuse, and addiction. They're used more and more interchangeably, but just so you have an idea about the history, it used to be that dependence and abuse were 2 different phenomena in the DSM, but they've been combined. And dependence used to be the more serious kind of problem you could have with a substance, and abuse would be just having a problem with that substance but not having the recurrent use. Like if you just occasionally drink too much and get a DUI, you could get classified as having some sort of drug or alcohol abuse, but not necessarily dependence unless you were reliant on it, you couldn't control your use. And those 2 have been combined. You can see with the brackets there, they've been combined in the DSM-5, and now we just rate the substance use on its severity. Okay, so those have been combined. Additionally, we have this word addiction, which is somewhat gets used interchangeably, but it's usually meant to refer not just to the physical dependence, but also to a set of behaviors that goes along with the dependence. So it might be, if you're dependent on opiates, there's some behaviors that go along with that, like skipping work so you can procure the opiates, lying to your doctor and saying, I've got this injury, can you prescribe me something? And so there's a set of negative behaviors that usually accompanies some sort of physical dependence. I'm going to use those 2 terms, dependence and addiction, however. I'm going to use them quite interchangeably. And Carnes uses the term sexual addiction, so he uses the word addiction. The other thing I want to say is, just as a kind of nuance to this, it is possible to be dependent on a substance without having an addiction to it, without having the negative behaviors. If you have severe pain and you're being treated in the hospital, you may temporarily become dependent on the opiates that they're giving you. That doesn't mean you're doing these negative things that you're lying to your doctor and that you're doing illegal things to procure the drug, but you still can develop a physiological dependence on the thing. The other thing I want to say is that, what we consider to be a drug drug dependence or addiction problem. Again, this is, again, completely society contextually dependent. Some of you probably like to read, and some of you probably could get lost in a book for hours and not really notice the time going by. But we don't really diagnose reading dependence. Now, but I did run across an article a long time ago, a historical article written in the Victorian era after novels started coming out in wide release, and some doctors were troubled by the fact that some citizens were spending hours reading, and they were ignoring their loved ones, and they were ignoring their duties. And they talked about some people having a reading affliction in this article. But today we would never think of that as a bad thing. We don't think about people who read too much. Similarly, we don't think about somebody who helps a lot of people and spends all of their time working with charities and giving to the poor. We don't see them as having an addiction because that's a societally sanctioned behavior. We didn't look at Mother Teresa as an addict, okay? So what gets defined as a behavior that you can do too much of is 100% depends on societal, sociological considerations. So one thing that Carnes gets into a little bit in the videos is, are all addictions similar? And what he notes is, now the DSM, we used to distinguish between behavioral addictions and chemical addictions. And by the way, there's only one behavioral addiction that's currently in the diagnostic manual. And do you know what that is? If you guessed gambling, you're correct. It's the only behavioral addiction that's in there. There have been some others that have been proposed to be in the DSM, like internet gaming disorder, shopping problems, sex addiction, but they've not quite made it to the level of scientific scrutiny to make it into that manual. But Patrick Carnes makes the point, and this is correct, that in many ways, all addictions, whether they're behavioral or they're chemical, are similar. They have, and his main point is his third point here, is that they have a similar neurological component. There's something that happens in the brain that's similar, no matter what you're dependent on, no matter whether it's coke or meth or opiates or alcohol or sex. There's some similar sort of dopaminergic things that happen in all addiction. Another thing you'll see, I'm going sort of backwards here in my list, is you'll see that and I've treated a lot of addiction in my lifetime, and you see a lot of similar problems between folks who are addicted to different substances or behaviors. You'll see that they struggle with impulse control. So they struggle with, denying themselves something when they want it. They struggle with emotional dysregulation. Their emotions tend to be a little less stable than the next person. So and some addicts have come to call that the addictive brain or an addictive personality. That's not usually really used in the field or in the research, but I think it's helpful to think that a lot of addicts of various things have some similar characteristics. And finally, a question that always gets asked here is that, yes, there's a lot of similar treatment for different kinds of addictions. And most addictions get treated using a drug. Let's get here. If there's a drug available, and that could be what's called an agonist or an antagonist, it's something that either blocks or inhibits the receptor site that drug bonds to. So I spent a lot of time treating heroin addicts, and we treated them with methadone, which basically filled up that site, the mu receptor that heroin bonded to, and made it to where nothing else could bond to it, essentially. But not everything has a medicine involved, but many things do these days. The other thing that's often used is some sort of CBT with the kinds of thoughts we're challenging are thoughts like, if I don't have this substance, I can't bear the pain. I can't live. I can't go to work without another hit of whatever. And this kinds of extreme thinking is what we challenge with the CBT. That you can't. It may be painful. It may be uncomfortable, but you can learn to tolerate the discomfort. And finally, the last one. This is really important, and I almost never treat very serious addiction unless the person has some sort of group intervention. And in the States and in a lot of other places, the most common group intervention is that of 12 steps. 12 steps has some science behind it. It generally does not come out of the scientific community. But I think, this is Debbie Quackenbush's opinion, I think there's some research that backs this up, that group support is hugely important in treating addiction. And think about it. If I'm your psychologist and I'm treating you, and you're having a craving for that drug or that behavior, and it's 12 o'clock midnight, you can't call me. My phone's off. We meet once a week for an hour, but you can call your sponsor, and you often can find a meeting to go to. And that's one of the steps, the strengths of these 12-step meetings. I have some problems with the 12-step meetings too, and a lot of people struggle with the religious and spiritual nature of them, and some of the steps that they have aren't very useful, I don't think. But I think the group component, being able to find a meeting pretty much anywhere in the world, is invaluable. When I used to work with people in Texas, I worked with people all over the world in a hospital setting, and when we discharged them, sometimes they'd even get discharged to their vacation home in Mexico, and there was always an AA meeting they could go to. So really important that you can, because your cravings don't stop. You get triggered around the clock, and to have people, a sponsor, people that you can call and say, can we get a cup of coffee and so I don't drink, is a really big deal. So that's all about addiction. We'll come back to this when we talk about Patrick Carnes.